Okay, great. Well, thank you, Ben, for the introduction, for inviting us to give a talk in this session. Today, Hugh and I, we're both PhD students at UC Berkeley Statistics, and today we'll be giving a little overview of some of our COVID-19 forecasting work as part of the U Group's efforts during this pandemic. And this project really arose out of a collaboration with a nonprofit organization called Response for Life. And our plan is to give you a high-level overview of the forecasting part with Response for Life. But then rather than focusing on the details of the modeling aspects of that project, we're going to take a slightly unconventional approach, and we'll be focusing more on the data aspects and the data repository that we've created that facilitated both our forecasting work and other quantitative efforts from the larger community. So, I mean, it's a nice coincidence that Corbin previously mentioned our data repository, and our hope is that maybe our repository might be of use or interest to many of you all as well. And so I'd like to start and emphasize that even though you and I are the ones presenting today, the work that we'll be talking about is certainly the work of a much, much larger team led by Ben Yu at Berkeley. Hopefully this slide gives you the sense of the scale of this project, and certainly none of it would be possible without each person here, especially Ben, who has been leading this fantastic group. Chandon was our student lead, and then Hugh and I were mainly working on the data parts, and Xiao and Nick here were the leaders of the modeling side. And so there have also been many others from Google and other institutions who have also been parts of this efforts. And so this really was a huge team effort. And it all kind of started back in March when things were starting to look pretty bleak in New York. And so I know we've all seen these headlines, cases and deaths spiking, hospitals over capacity, and huge shortages of PPE. And around that time, we teamed up with a nonprofit organization, Response for Life, to try and help with hospital supply and resource allocation. And the overall goal of Response for Life was to distribute PPE, face shields, and other medical supplies to hospitals in need. And we signed on to help Response for Life figure out which hospitals are in need of PPE and medical supplies before things become too dire. And so at a very high level, what we wanted to do was predict the number of PPE that each hospital has, and as well as needs. So this is the ideal prediction problem that we would like to solve, but unfortunately that data doesn't exist. So we tried calling up hospitals to see like how many masks they have, are they in need, how many would they need, but most hospitals themselves don't really know how many masks that they have at a given point in time. And so we thought, well, the next best thing might be, let's look at the number of patients in each hospital who are hospitalized with COVID-19, those with severe cases. But again, at the beginning of the pandemic, that data also did not exist. What we actually had to work with at the time was the number of COVID-19 deaths at the county level. So we were interested in trying to predict how many COVID-19 deaths there would be in the next maybe 2 weeks for each county in the US. And of course, there are a few jumps that we would need to make to argue that predicting the number of reported deaths is a good surrogate for hospital supply need. But our mindset is that while it's not perfect, it should be good enough for distributing PPE in this wartime situation. Okay, so how do we approach this problem of predicting COVID-19 deaths at the county level? Well, first, we needed data and had to collect this data ourselves. At the beginning of the pandemic, there was obviously no existing database labeled, here's everything you need for COVID-19 prediction problems. Gathering this data was very much part of our job, but then using this data, and after gathering it, we explored various models to predict the number of deaths for each county. And we eventually developed this model with which was an ensemble of fairly simple linear and exponential fits, by which I mean, let's look at the COVID-19 deaths over time, fit a simple linear model and a simple exponential model and a few others, and then combine them using adaptive weights. In particular, we're going to give higher weights to the models with better historical performance, and then lower weights to the models with worse historical performance, and then just average them in this way. So It's a relatively simple model, which makes it nice from an interpretation point of view. And then we've also developed a method to obtain prediction interval estimates with fairly good coverage for our ensemble model, and then as well as lots of visualizations for our predictions. And so this is a very brief rundown of our approach and model, but once we develop this model, now comes the fun part. Using our predictions, Response for Life was able to use them as a very heuristic guide for sending out face shields to hospitals, because as we know, like the data is not perfect. So this was it was a good sanity check and heuristic guide for Response for Life. And with that, they have distributed thousands of face shields to various places across the US. And it's been exciting to see and learn about the various shipments and medical supplies as they go out. But in addition to sending out masks, there have been a few other things that have come out of our work with Response for Life. For one, Response for Life is building a Salesforce logistics system for supply chain that's using our forecasts. We also have some interactive visualizations on our website, covidseverity.com. And then finally, we created a large COVID-19 data repository, which is all open source on GitHub. And so for the remainder of the talk, I'd like to focus on this data repository and highlight some of the aspects in data curation, as this area can sometimes be overlooked, but yet every analysis that we do, all the numbers, it all starts with the data, and without any data, there's nothing that we can do. And hopefully, like by getting a better understanding of maybe the limitations of this data, we can improve our analyses. And so, in particular, we'll give a high-level outline of what our data processing pipeline looks like, also give an overview of the data that we've gathered thus far, and then finally we'll dive into a short case study with looking at the USA Facts data and their COVID-19 cases and deaths, with some discussion on possible biases that are especially important to keep in mind when doing any kind of analysis with COVID-19 data. Okay, so with that, what does our data pipeline look like? It first starts with finding and gathering data from various websites, and so far we've collected data from across more than 20 sources and counting. So we're always constantly looking for new data sources, incorporating them into our pipeline and repository as they come up. But after gathering the data from the websites, we've written and automated some Python scripts to do some basic data cleaning for each data source, handling missing and erroneous entries as we see fit. And then beyond data cleaning, we are also checking some for data validity as best we can. So there aren't anything too crazy in the data that we are compiling together. And so Hugh and I have been working on this essentially full time during the spring semester, and then we're continually adding on new data sources as they keep popping up. And then everything is publicly available on GitHub. You can easily download the data in a single line of code. And it's been being used by multiple research groups across the country, as well as some university classrooms as well for projects. Just to give you an idea of the kinds and scale of the data that we've collected, here's just a slide with all of the various sources that we've cleaned, validated, and incorporated into our repository. We've got data on number of COVID-19 cases and deaths for each county from both USA Facts and New York Times. We also have lots of supplementary county level data, that is data measured for each county in the US, from things like CDC, some social mobility data groups, etc. And then to facilitate our goal of aiding allocation of resources to individual hospitals, we also created a hospital level data set with various statistics for each hospital. Here's just a bird's eye view of the county level data that we have in the repository. It includes things like, again, COVID-19 cases and deaths, demographics, including population density, age structure. There's also health risk factors, particularly those pertaining to COVID-19, like heart disease, stroke prevalence, respiratory disease, smoking, diabetes. Some socioeconomic risk factors, if you would like to stratify on those, like unemployment, poverty, education. There's some social distancing data, which has been really interesting. And then some other kinds of miscellaneous data sets like flight itineraries if you're interested in the spread of COVID-19. And then like on the hospital level side, we have about 7,000 hospitals in the database with various features like their location, address, the county that they're in, type of facility, whether they're teaching hospital, short-term acute care, critical access, maybe it's an urban or a rural hospital, and then other statistics like number of beds, ICU beds, and occupancy rates. All right, so hopefully this gives you a pretty good sense of the types of data that can be found in our repository. I'll next pass it on to Hugh, who's going to walk us through one of our COVID-19 data sets more carefully.
Thank you, Tiffany. So I will talk about mainly about the possible biases in USA facts COVID-19 data because this is one of the primary sources we use for our data processing pipeline and later prediction pipeline. So the first thing we look at is the weekly patterns in the USA facts data. So if you look at plot A, this shows you the cumulative death counts per weekday until June 21st. As you can see, there is a weekly pattern. On Sunday and Monday, the total death count are significantly smaller than the rest of the weekdays. We don't have a proof why this happens, but we doubt this relates to how hospitals report their death counts. And the second possible bias in the data is the historical data revision. What we mean here is sometimes USA Facts will release their data, but later they will revise the data they released previously. We found that until June 21st, there are around 2,100 revisions happened for some counties at some day. In plot B, you see the time lag in revisions, and this is histogram, normalized histogram. So as you can see, about half of the revisions happen one day after the data is released, but some of the revisions happen much further. So sometimes they will revise their data a month after they release it. Plot C shows you the magnitude of the revisions. As you can see, most of the revisions are upward, meaning that the originally reported death counts is smaller. But there are also cases where they revise their originally reported death count to be lower. So that's mainly due to some error the local agencies made when they first report the data. Also, another thing to pay attention to here is that sometimes the magnitude of the revisions can be very large, can be as large as 1,000. We also observe some inconsistencies between different data sources. In particular, we have in our repository, we have data from USA Facts and the New York Times. While they both report case and death counts, sometimes they report different numbers for some counties at some date. In this plot, you see so each dot corresponds to one county at a particular day, and the y-axis shows you the magnitude of the difference between USA Facts and the New York Times. Most of the differences are pretty small within 50, but sometimes the difference can be as large as 250. There are a couple of reasons why we observe this difference. First is New York Times and USA Facts, they tend to update their data at different times. New York Times says they update their data
5
continuously.
minutes.
And the USA Facts have a fixed time to update their data. And the second possible reason is they deal with probable death in a different way. So after mid-March, we have both the deaths that we know for sure related to COVID-19, but there are also another column called probable death. And New York Times and USA Facts might deal with probable death in a different way. Also, since USA Facts and New York Times didn't really articulate how they process the data from the local agencies, so they might this difference might due to their different data processing pipelines. And we view these multiple data sources as a blessing for our later modeling pipeline because it gives us some insights into the caveats of this data. Some numbers are not accurate, and we need to really be careful when we model the death count using either of these data sources. So as a summary, our data repository can be found at this link. It's updated daily. We host it on AWS EC2, and we have a lot of documentation about each data set. We have about possible biases and what's the meaning of different columns. And we make sure it can be easily download and clean and merge in one line of code. And we have a paper that documents how we do this, both for the data part and for the later modeling part. And all the previous plots are from the paper. If you want to know more about the detail, you can check out this paper. And thank you.
Thank you, Hugh and Tiffany. We have a question. One of our attendees mentioned that for hospitals, they remember digging up information on bed availability in news articles, web pages, and et cetera for something called COVID Care Map. Is the situation better, or are you still, for data collection, do you still need to crowdsource and scrape the data?
I think over time it has been a little bit easier to find hospital level data. I guess one thing we haven't done too much is compare the hospital level data across sources. I know there's been a couple different sources with different numbers of hospital beds and for each hospital, and we haven't really compared or like looked at the differences between sources as we did with the COVID-19 cases and deaths data. Yeah, Hugh, do you have anything else to add to that?
Yeah, so I think currently we are having some data from the California state about the hospital occupancy rate, things like that. But we currently our public repository we are not allowed to include this kind of information.
And for our last minute, I just had a quick question. Do you have, this is not necessarily something I'm going to be able to answer in a minute, but do you have any thoughts on data governance with regards to documenting how the data was collected and suggesting how other people should document their data collection processes?
Yeah, I think if anything, this like looking at all the COVID-19 data, it's brought even more importance to documenting the data really well so that people understand the caveats and the limitations of the data and the potential problems as we're seeing in things like the USA Facts and New York Times. These aren't things that we can necessarily could fix, but they're just important to keep in mind whenever interpreting the results of our analyses, I think.